Okay, so let's continue talking about low testosterone and dive into some of the things that people should be focusing on should they have a blood test that shows that their testosterone level is low. By itself, it's really actually quite meaningless. So I've already been over the fact that time of day matters, but really you need to have a very big picture because the number by itself really doesn't mean a whole lot. You're going to need to get a blood draw that has testosterone, free testosterone, bioavailable testosterone, SHBG, that's sex hormone binding globulin. You're going to want to get an LH, an FSH, a prolactin, get an idea of how your pituitary function is. You're going to want a TSH. You will want to have not just T4, but also T3 and reverse T3. Your thyroid function is very important. In fact, I think it was Dr. Phil Esposito that discussed how thyroid function can actually cause people to have low testosterone levels because T3 is necessary for a process called STAR. It's an acronym. What it's talking about is it's the ability of your testicles to pull cholesterol into the testes to begin the process of making testosterone. But in any case, the point being, low thyroid, like if you have Hashimoto's, you'll have low testosterone. It has nothing to do with your testicles being, primary hypogonadism. You don't have testicular failure. You don't have pituitary hypofunction. You have low thyroid. And oftentimes that gets missed in men because there's this, well, it's true. Women are more likely to have Hashimoto's than men are. But at the same time, that doesn't mean that men don't get Hashimoto's. Like, just because women are more likely to have Hashimoto's doesn't mean that it doesn't happen to men. So that's something that should be checked as well, which means that you also want to get some of the antibodies checked. There's like TPO antibodies and TG antibodies that should be checked to make sure that you're not suffering from an autoimmune condition where you're attacking your own thyroid. So that's one of the things that I really think is very important, is that if you have a low testosterone level, you need to look at the big picture. It really matters where those other numbers are at, because very quickly you can find out, oh, geez, it's actually my thyroid. And in that case, you need to get treatment for your thyroid. That's duh. If you have a thyroid problem, obviously you want to get treatment for your thyroid. Stupid comment. But, let's say your prolactin level's high. Well, as I mentioned before, you could have a pituitary tumor. There's microadenomas, there's macroadenomas. Some of them are prolactinomas. Some of them require surgery. And you should definitely get that checked. That's why you need to get a brain MRI. You should get an MRI of your pituitary gland. Make sure that there's no tumor in there. And I think that's important even if you don't have high prolactin levels, because not all adenomas are secreting. And at the same time, as I tried to warn in previous videos, those adenomas, if left unchecked, can become very serious because they can grow into your artery. There's a carotid artery, then they can put pressure into that. You can also go blind from them. If they grow in a certain direction, they'll push into your optic nerve, and you could lose your eyesight. I think that's probably more important to most people than whether or not your testosterone level's low. Like, hey, I would rather have low testosterone than go blind. But you know what? We can fix both, because by addressing the pituitary tumor, your testosterone level will come back to normal, and as well as it will save your vision. Not all of them are surgical. There are medications, bromocriptine, cabergoline, and pramipexole, I believe, are the dopamine agonists that they use to treat those. You'll have to double check me, because I know that sometimes we no longer use, I think pramipexole is no longer used because cabergoline works better. But it might even vary by what country or state you're in, or your practitioner's preference. So there's those things that matter. You'll also want to get an ACTH and a cortisol level, because if you have excessively high cortisol levels, that obviously will impair your testosterone production. And then, of course, the other thing that I would like to point out to people is look at your estrogen level. If you are carrying adipose tissue, body fat, you have higher levels of aromatase. It's an enzyme that converts your testosterone into estrogen. So whenever you're carrying any excess body fat, in fact, actually, you don't even have to have a whole lot of excess body fat. I've actually seen this happen in guys who are really not terribly over fat, like 15%. It just seems that some people have higher levels of aromatase. which is an interesting thing in itself, and that's something that probably needs to have more research on it. But some men definitely aromatize more than others, even at the same body fat level. So it's very possible that you actually produce adequate amounts of testosterone, but then your body has too much aromatase enzyme, and then it converts it into estrogen, which is causing you to have low testosterone as a serum level. But in reality, it's that you're actually producing more than adequate hormone, and instead you're ending up with more estrogen than you should because you're aromatizing, in which case they'll probably just use an aromatase inhibitor, and you could lose some body fat. But yeah, I mean, that's obviously an option. There are multiple aromatase inhibitors. There's anastrozole, aromasin, letrozole. There's even some research suggesting that SERMs, like clomiphene or tamoxifen, I think tauromephen, I don't know how that's supposed to be pronounced, I've only seen it in writing, and raloxifene can also be used to manage that, because there's actually a feedback loop with your estrogen level. So as your estrogen level goes up, it actually suppresses, the hypothalamus picks up on this and says, oh, we have too much estrogen, which then causes it to reduce the amount of gonadotropin releasing hormone. So now there's less gonadotropin releasing hormone being sent to the pituitary gland. And like I said, it's a big feedback loop. That's why all these environmental estrogens can actually screw you up. If you're getting a lot of estrogens, phytoestrogens and stuff like that, or even just like these weird xenoestrogens, all that excess estrogen going into your body actually screws up that feedback loop, and so then your body thinks it has too much estrogen. So, as I stated, obviously, you need to get more blood work. You need to get an MRI, and then the last thing I would recommend to people would be to get checked for a varicocele. I think that's really important. I really do. I think that they go massively underdiagnosed, especially in people who lift weights. It's amazing to me how many people tell me that I have low testosterone. I'm like, have you been checked for a varicocele? And they're like, no. I'm like, do you have any testicular pain? No. And then I hear from them a few months later, and they're like, oh, I'm starting to have a little bit of pain in my testicle. And I'm like, did you get checked for a varicocele? No. You should go get checked for a varicocele. I'll worry about it later. Finally, they come around and do it, and they get an ultrasound. That's all it is just an ultrasound of your testicles. And sure enough, they had a varicocele the whole time. They either get a ligation, which is a very simple outpatient surgery. They go in and ligate, or I think it's called an embolization, where they just drop a coil in through an interventional radiologist. It's very simple, another outpatient procedure. And just like that, the varicocele is gone. Your sperm production and your testosterone production come right back to normal. So those are the things I would look for. If you do have a varicocele, so first off, you want to start with the ultrasound, but obviously, if you do have a varicocele, you might want to get a CT scan of your abdomen with contrast, and that will show whether or not your superior mesenteric artery is pushing into your left renal vein, which is then causing a retroaortic left renal vein, which is then causing you to develop varicoceles downstream. If that's the case, then you probably are going to have like a stent or something like that put in to make sure that the artery doesn't continue to just compress that vein, which is another simple outpatient procedure. Interventional radiology does those all the time, and once that's addressed, your varicocele will resolve, and you'll be fine, and it won't come back. If you get it ligated and you don't check for that, it will come back. That's very important to keep in mind. So like simply just ligating it, if your artery is pushing into the vein, you'll just end up having a varicocele in a couple months all over again. Yeah, that'll just come right back. So those are the big things I would suggest that people start with, is getting those things done. And of course, if any of those numbers, as I mentioned, the LH, the prolactin, all the stuff like that, your IGF-1 even, if any of those numbers are screwed up, you'll probably want to talk to your doctor about getting a glucagon stimulation test done to make sure that your pituitary function is intact. This is why you can't just throw testosterone into the equation, because if you don't fix these underlying things, you're still going to feel like shit, because you have other issues. Like if you don't address the thyroid problem, you're still going to have low energy, you're still going to feel awful. Even if you just start injecting 100 milligrams of testosterone a week, it's not going to fix everything. That's why you have to fix these underlying things before you even consider whether or not you'd introduce a medication.